So chemosaturation is derived from the idea that we know that there are some tumours which are quite resistant to chemotherapy at the doses we can achieve if we inject them into the vein, into a systemic drug. And that's because there are lots of tissues within our body which are sensitive to drug, bone marrow, hair, and often what limits us in our treatment of our patients is the side effects to the drugs. Now, if we can isolate the liver and treat the liver alone, then we can achieve much higher doses of drug and we can avoid the systemic side effects which are often what prevent us from escalating the dose. And that means the treatment's better tolerated. Because we've isolated the liver, we can focus our treatment just in that one area, it's a tiny part of the body effectively. We can use a much higher dose of chemotherapy than we could ever use if we were injecting it systemically. And the treatment is going to where we want it. It's going to the tumour and to the bulk of the tumour in that patient's body. We're using the anatomy and the advantage of the liver having a dual blood supply to target and isolate the liver and therefore achieve a better result in that area without the unwanted side effects which are systemic. These are early days. This is a new technique. It's an evolving technique. But what we're finding is we are getting very good anti-tumoral effects with the patients that are being treated. Now, in my practice, I've been treating patients with eye melanoma particularly, and we see from our results, our early results, that undoubtedly the treatment is working in terms that the tumours are shrinking, patients are living longer. The next thing is, can we show this shows real value and real benefit for patients with other tumour types? I think that it's unrealistic to expect that a liver-directed therapy would offer a cure, but that doesn't mean that we can't offer very long-term survival, and that's what our aim is currently. The chemosaturation procedure normally lasts for about 2 to 2.5 hours. Performed in an interventional lab, the anaesthetist puts the patient to sleep and puts in the lines so we can monitor the patient during the procedure. I put in a catheter into the liver artery so we can deliver the chemotherapy, and then the venous catheter, which is the clever bit of the circuitry which allows us to isolate the blood coming out of the liver. Once we've got those in place, we thin the patient's blood and put them on the bypass circuit. If we're happy that the bypass circuit is running well, we'll then start infusing the chemotherapy. That lasts half an hour. Once we've washed the chemotherapy out, we then reverse the clotting and remove the lines. And once that's all satisfactory, the patient's woken up and taken back to the recovery area. So there's the insult of the intervention, so it's an anaesthetic that goes on for 2 to 3 hours, and patients therefore feel certainly groggy the first night. By the following morning, most patients are eating normally and starting to feel back to normal. Most patients, when they go home, day 4 or 5, are feeling pretty normal. We keep a close eye on them for about the next 2 weeks to make sure there's no evidence the bone marrow has had any dose of the treatment. There are occasional patients, so I would say 1 in 10 patients, when their counts start dipping, as they would with normal chemotherapy. And if their counts dip, then we either give them something which boosts their bone marrow, so that's an injection, or occasionally patients do need transfusions of platelets to make sure their blood doesn't get too thin. That's a temporary measure until the bone marrow starts working normally again.